My name is Dr. Ken Moghadam, and I'm the Medical Director at Austin Fertility Institute. I'm a board-certified reproductive endocrinologist, fellowship-trained in treating couples with infertility. I've had the good fortune of working in Austin and also at Austin Surgical Hospital over the past year. We've had the privilege of helping many couples achieve their dreams of becoming a family. I have the privilege of speaking to you from our state-of-the-art IVF treatment unit here at Austin Surgical Hospital. In 2010, we designed this unit to tailor to the needs of women seeking fertility services here in the greater Austin area. Our unit consists of a 4-bed recovery and reception area, a separate procedure room that is distinct from the operating rooms here at Austin Surgical Hospital, and a state-of-the-art IVF laboratory. In general, we not only work with patients seeking fertility services, but also complex reproductive care issues, including recurrent miscarriage, polycystic ovarian syndrome, endometriosis, and their care may involve something as simple as medications and observation to as complex as in vitro fertilization. Infertility is defined as 12 or more months of failed conception following the discontinuation of contraception. It may be defined earlier in couples that are older. Specifically in women that are over 35, many authorities suggest evaluating for different issues after 6 months of unprotected intercourse. The basic evaluation involves looking at 3 different categories of investigation. One would be ovulation and hormones in the female partner. The other would be looking at uterine and tubal architecture. And the third would be looking at the male for his fertility potential. In short, hormones, plumbing, swimmers. And when the patients present, a lot of times they've been following their cycles and looking for different things. What I like about what I do is that it presents me with an opportunity to work with couples, and in general these couples are pretty savvy about what's going on with them, and many times they bring a good amount of information to the table, and we're just kind of expanding upon their knowledge. So when we're looking at ovulation and hormones, typically we'll look at blood work, ultrasound, and certainly menstrual history is very important. When we're looking at uterine and tubal issues, we may do an outpatient surgical evaluation at Austin Surgical Hospital. We may do a X-ray dye test called a hysterosalpingogram, or HSG. And we also may do an office ultrasound, specifically looking at the uterus. Any of these tests can be used, although some may be more important to look at more detailed aspects of their evaluation than others. These evaluations allow us to determine which treatment pathway is best based upon the patient's pelvic anatomy. Polycystic ovarian syndrome is an endocrine disorder that affects 5 to 10% of all reproductive age women, making it the most common hormone-related disorder in this age group. Specifically, what we find with these women is that they have irregular cycles, fewer than 9 menstrual cycles in a 12-month interval, evidence of elevated androgens, androgens specifically being male hormones. So even though they're not elevated in the male range, they're still upper limit of normal in the female range, and they may also have problems with excessive hair growth in the midline, upper lip, chin, lower abdomen. And then the third criteria is lots of little circles in their ovaries on ultrasound. You need specifically 2 of these 3 criteria to diagnose the disorder. Now, these women not only have issues with their menstrual cycles, but they also have issues with fertility. Furthermore, long-term, they may have problems with diabetes, metabolic syndrome, which is a problem that's more common in older women and may present with hypertension, high blood pressure, what have you. And then specifically too, they may require stronger medicines or other treatments to allow their ovaries to do what they're supposed to do. Now, with these women, it really depends on where they are in their reproductive years and what their goals are. And that's in fact the question I always ask these patients: so what are your goals in the here and now? If they desire to get pregnant, then certainly the template for their ovaries to do what they're supposed to do is right there. We just need to give their ovaries medicines so that they produce eggs from the follicles that are already there and put themselves in a position to get a pregnancy. If they desire to control their cycle and just be predictable like their peers, then we can give them birth control pills or other medicines to regulate their cycle until they do have some family planning goals. When looking for male factor, specifically you start with the semen analysis. The count needs to be greater than 20 million sperm per milliliter of specimen. The motility, which is the percent moving sperm, needs to be greater than 50% per specimen. And you want also to look at the morphology. and that's the percent normal shape sperm. What many people don't realize is that the majority of the sperm in a specimen are actually going to be misshapen. And so what we're looking for is 4% of that specimen to be normal in shape. Depending upon what the workup shows, we certainly want to use all three categories of investigation to formulate a treatment plan. What I always emphasize for patients is that we're not going to take a cookbook approach to your care. We want to make sure that we bring all the information together to provide an individualized treatment approach for that couple. Following egg retrieval, the eggs acclimate or adjust to the laboratory environment, followed by introduction of egg and sperm about 4 to 6 hours after retrieval. The embryos are then cultured in incubators over a period of 3 to 5 days. In those 3 to 5 days, we are meticulously checking on them to make sure that we're giving them all the attention and nutrients they need and communicating very closely with our couples about their progress. What I really like about working here at Austin Surgical Hospital is that it has its roots as a women's hospital, and it's designed to basically meet the needs of the women that we take care of. This is kind of a back to the future component of this hospital, even though it has its reputation currently as an excellent surgical hospital. I've always considered it a great privilege to work with couples. Trying to have a family is a really stressful time, and what I always emphasize to patients is that there's 3 components in private practice: affability, how nice you are to people; availability, how easily they can get to you and get their questions answered; and ability. While we certainly take great pride in our ability, we definitely put a lot of emphasis also on the first 2 approaches, since that's what's in your control. We've been very fortunate to have the opportunity to work with many couples in the Austin area, and in particular at Austin Surgical Hospital, the IVF facilities have brought us promising pregnancy outcomes in just a short time. We look forward to many, many years of productive care here in Austin, and we certainly feel that Austin Surgical Hospital is a premier facility for that care.